I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist from McMaster University in Canada, and I'm absolutely delighted to have with me today Dr. Scott Solomon, the Edward D. Froelich Distinguished Chair and Professor of Medicine at Harvard Medical School and Brigham and Women's Hospital, and Dr. Mikhail Kosiborod, who is Vice President for Research at St. Luke's Health System and Professor of Medicine at the University of Missouri, Kansas City. And we are here to discuss recent evidence to support the use of SGLT2 inhibitors in heart failure across the EF spectrum. Welcome, Professor Solomon and Kosiborod.
Thanks, Harriette.
Good to be with you.
Dr. Solomon, perhaps I will ask you first to provide the context for the trials we will discuss today. The trials are DELIVER, DEFINE-HF, PRESERVED-HF. Can you give us a brief overview of the evidence to support SGLT2 inhibitor use in heart failure?
I'll do my best. So, of course, all of your listeners and viewers know that SGLT2 inhibitors are drugs that were designed to essentially reduce glucose in patients with diabetes. And they were tested in large cardiovascular outcomes trials to make sure that they were safe for this purpose. And lo and behold, unexpected finding in the EMPEREG trial of a dramatic reduction in heart failure hospitalizations and cardiovascular death. And these are not in patients with heart failure, but in patients with diabetes who were at risk for heart failure. Same thing shown in two other trials, CANVAS and DECLARE, and that, of course, made everyone think that these drugs might also be beneficial in patients with heart failure and in patients with or without diabetes. So fast forward a few years, and the first trial to show a benefit in patients with heart failure was DAPA-HF. It was about a 4,800 patient trial in which there was a really substantial reduction in cardiovascular death and heart failure hospitalizations, about 25% overall reduction. There was also an 18% reduction in cardiovascular death in the DAPA-HF trial. And this was in patients with heart failure who did and did not have diabetes. So it wasn't just in patients with diabetes. So that was the first demonstration that these drugs could potentially be beneficial in a broad range of heart failure patients. The EMPEROR reduced trial tested basically the same kind of patient population as DAPA-HF, very similar overall results. And then last year at the ESC, the results of EMPEROR PRESERVE were presented, and that was a group of patients with heart failure with ejection fraction of over 40%, so preserved and technically mildly reduced ejection fraction with a overall 21% reduction in a composite of cardiovascular death and heart failure hospitalization. So right now, there's really a substantial amount of evidence for the use of SGLT2 inhibitors in patients with heart failure.
Right, and similar reduction in heart failure hospitalization across EF with less so of an effect on cardiovascular death at the higher range of the EF spectrum. Mikhail, perhaps I'll come to you now and ask you to provide some context with regards to the trials you presented at HFA, defined, preserved, pooled analysis. Tell us about the research question and how you sought to answer the question in your analysis.
Right. Well, as Scott mentioned, even prior to this analysis, there was extensive data already demonstrating really substantial benefits of SGLT2 inhibitors on important outcomes in patients with heart failure. Again, just as a kind of level set, the triple goal of care was what we call triple goal of care in heart failure is to make patients live longer, stay out of the hospital, and then feel better and be able to do more. And we had evidence that SGLT2 inhibitors actually have meaningful benefits in all three of those important goals of care in heart failure with reduced ejection fraction. That was very clear. and consistent across different agents, both dapagliflozin and empagliflozin within the class. And then we have emerging data from patients with heart failure preserved AF, where we have evidence of outcome benefit from Emperor preserved. And we actually had results of the preserved HF study, which is smaller and US based, but nevertheless showed very robust health status benefits, so symptoms, function, quality of life in patients with HFpEF with dapagliflozin versus placebo that we presented last year and published subsequently. The idea behind pulling our data from 2 investigator-initiated trials of dapagliflozin versus placebo in the reduced AF population, which is defined HF, and the preserved HF, preserved AF heart failure population, preserved HF, was really to try to understand whether the health status benefits, so that's predominantly effects of SGLT2 inhibitors on symptoms, physical limitations, and quality of life, are consistent across the range of ejection fraction. Why is that an important question? Well, it's kind of important to go back to Emperor preserved in particular, where there was a question raised about the effects of empagliflozin versus placebo in those patients with truly normal ejection fraction, especially as it gets above 60%. And as you recall, there was this on clinical outcomes like CV, death, or hospitalization for heart failure, there was this kind of what appeared to be visually a possible slight diminution of the benefits above that EF. And actually, in a combined analysis of Emperor reduced and preserved, there appeared to be diminution of health status benefits above ejection fraction, about 60% or so. But kind of to reinforce some of the doubts about this, the p-value for interaction for the clinical outcomes was not significant. And frankly, if it was anything but ejection fraction, we probably would have dismissed it outright and never paid any attention to it, given all the limitations of subgroup analysis. And, you know, for the evaluation of KCCQ, or Kansas City Cardiomyopathy Questionnaire, which is a gold standard of assessing symptoms, function, quality of life, you know, there appeared to be a similar kind of lessening of the benefit, but the health status benefits in Emperor preserved were relatively modest to begin with. The questions that we wanted to ask and answer is, you know, if we combine the data from our investigator-initiated trials based in the United States, where the effects of dapagliflozin versus placebo on symptoms, function, quality of life appeared relatively robust, do we see any evidence of any change in the effect of dapagliflozin versus placebo across the range of ejection fraction? And is there a similar diminution of benefit that was observed in other studies, like Emperor preserved and Emperor reduced pooled analysis that was recently published? So that was really the question. And I think it's a very important question because, again, it's a very important goal of care, making our patients with heart failure feel better and be able to do more. And being able to say that you can get that benefit if you have heart failure, regardless of what your ejection fraction is a very important clinical message. So that's what we did in an analysis, and the primary outcome was actually Kansas City Cardiomyopathy Questionnaire clinical summary score, which is a combination of symptoms and physical limitations.
Right. So the magnitude of treatment effect often depends on your baseline health status. Tell us about how your baseline health status in this group of trials were similar to or different from those in the Emperor group of trials.
So the important differences in baseline characteristics are critical here because they likely explain some of the differences in the results that we observed versus the results of other trials. And those actually include other trials of both empagliflozin and dapagliflozin. I think the most important is that this was a much more diverse group of patients, about, you know, between 40 and 45% of these patients were women. Actually, a third of the patients were Black or African American, which is much higher proportions than what you typically see in global trial programs. And then perhaps most importantly, these were patients that had much higher BMI a much higher proportion of substantial symptoms or severe symptoms. So the proportion of patients with NYHA class 3 was more than 40% or just about 40% versus closer to 20% in global programs generally. And the KCCQ at baseline was much lower, and 6-minute walk test was quite low as well, indicating that this is very symptomatic and functionally impaired population of patients. Now, if you have an efficacious agent that actually has a benefit when it comes to symptoms and physical limitations, it would logically follow that the more symptomatic and functionally impaired your patient population is at baseline, the more likely you're going to observe a significant benefit. And I think that's part of what we're seeing here in terms of the trials that we presented at HFA versus other trials of SGLT2 inhibitors that were presented previous to that.
Right. So pretty good uptake of medical therapies at baseline. Would you agree? And
Absolutely.
you included all EFs across the spectrum, except for perhaps 40 to 45% based on your eligibility criteria for each of the trials?
Yeah, actually, the only EFs that were excluded were 41, 42, 43, and 44%.
Yeah.
And as we all know, usually these tend to cluster in fives, right? So there are probably very few patients we actually missed because in a defined HF, you could be included up to ejection fraction of 40%, and preserved, you could start at ejection fraction of 45.
Right. Okay. So tell us about your findings.
So a couple of kind of quick highlights. First of all, when combining these two trial patient populations, we had roughly about 600 patients, just under, and there was a significant benefit across the entire population of dapagliflozin versus placebo, and looking at the KCCQ clinical summary score of about 5 points, highly statistically significant and clinically meaningful. Importantly, when we looked at the effects across different subgroups, and of course, the most important subgroup in this particular analysis was the ejection fraction, and we had a good distribution of EF all the way down to less than 10% to as high as 80%. We saw very consistent findings and nearly identical results regardless of the ejection fraction. In fact, when we evaluated the effects of dapagliflozin on KCCQ with ejection fraction being factored as a continuous variable, we saw that that relationship between effects of dapagliflozin on KCCQ and ejection fraction was a flat line, indicating that the effects were essentially identical, regardless of what the ejection fraction was. And the p-value for interaction between dapagliflozin versus placebo, EF, and KCCQ was 0.94. So about as close to one as it gets, indicating that it doesn't matter what your EF is. There was absolutely no evidence that the benefits of dapagliflozin are any different. And there was no evidence of any diminution of dapagliflozin's benefit on KCCQ above ejection fraction of 60%. So these are somewhat different from other trials had suggested before. We also looked at something called the responder analysis, which is what proportion of patients get small, moderate, and large improvements, and how many actually have worsening of their symptoms and physical limitations. And very consistently, again, completely independent of ejection fraction or regardless of ejection fraction, fewer patients treated with dapagliflozin had worsening in their symptoms and physical limitations, and more had small, moderate, and large improvements. And again, mattered none of what the ejection fraction was. We actually saw, perhaps, importantly here, when you look at proportion of patients with very large improvements, so that's 20 points or greater, and that's essentially kind of, just to put it in a framework of NYHA class, even though it's not a perfect comparison, there are lots of inconsistencies from KCQ, which of course comes from a patient standpoint, and an NYHA class that comes from a physician standpoint. But nevertheless, a 20-point shift in KCQ is about a change in NYHA class. So going from class 3 to class 2 or class 2 to class 1. We saw more than double the proportion of patients on dapagliflozin getting that larger with improvements than we saw with placebo. So these were pretty substantial improvements, pretty substantial differences favoring dapagliflozin.
Okay, well, I'm going to turn to Scott and ask him to tell us about Deliver and the knowledge gap it fills in terms of the patients who were recruited into that trial.
So Deliver, which we will be presenting at the ESC in just a few months, is actually the largest trial so far in heart failure with mildly reduced and preserved ejection fraction. We ended up enrolling 6,263 patients. And although the patient population is relatively similar to some of the other trials in heart failure with mildly reduced and preserved ejection fraction, there are some important distinctions. So as you remember, in many of the trials that preceded Deliver, we actually did have an ejection fraction, a lower ejection fraction cutoff of 45%. In Deliver, we went down to 40%, which is also what was done in the Emperor Preserve trial. There are a couple of very important distinctions between Deliver and Emperor Preserve. One is that Emperor Preserve excluded patients who were hospitalized within 30 days of enrollment, and we didn't do that. We accepted and enrolled patients who were either in hospital or recently discharged from the hospital in Deliver. Second, we included a group of patients in Deliver that has actually been excluded from every other trial so far. And these are patients with heart failure and so-called improved ejection fraction. We used to call that recovered ejection fraction. And these are people who had at one point an ejection fraction measured at below 40%, but then their ejection fraction has climbed up to over 40%, and they're eligible for the trial based on that. We excluded those patients from Paragon. Emperor Preserved excluded those patients, but we have to know how to treat them because many of these people show up in our clinics, and we don't have a really very good evidence for treating these patients. So 18% of our patients in Deliver are improved ejection fraction, and about 10% of our patients are enrolled within 30 days of a heart failure hospitalization. So those are the primary differences between Deliver and the other trials.
Right, and each of these trials use different thresholds for inclusion when it comes to ejection fraction. And of course, there are many considerations that go into that. So we do have various thresholds in different trials. Why did you choose 40%?
Well, we chose 40% because we realized, and perhaps it's taken some time for the field to mature a little bit in this respect, we realized that this was where the knowledge gap was. In patients with an ejection fraction over 40%, we did not have really any clinical trials tested in those populations that have been positive. We didn't have evidence-based therapies in patients with an ejection fraction over 40% because we've all of our HFrEF trials have been either 40% or under, or some even 35% and below. So we thought this was the gap in knowledge. Previously, and I was obviously involved in many of the previous HFpEF trials. There was a desire to be pure about who these patients were, to raise the ejection fraction so that we didn't get splay. And we know that EF is a variable measure. There are no cutoffs in biology. If we take a patient and measure their ejection fraction at 43%, it could actually be under 40. It could be 47% or 48% or even higher. We have to be aware of that. But we felt that because DAPA-HF had been done in patients with an EF of 40% or below, we wanted to fill the rest of the spectrum and not have a donut hole in the middle, as we had with the Paradigm and Paragon trials. Even though, interestingly, when we actually measured ejection fractions in a core lab in the Paragon trial, about 11% of the patients had a measured EF in our core lab that was below 45%. So these are variable measures.
Yes, there's variation. So slight under-enrollment, I would think of Black or African-American patients and Indigenous patients, a good representative sample of women. What do you think about the baseline medication use, the use of ARNIs, for example?
Yeah, well, first of all, I mean, I agree with you about underrepresentation, but it has to do with where we do our trials, and we can, that's a completely separate topic. In the United States, we actually had very good representation of Black patients, but it was only one country, and most of the other countries didn't have Black patients to enroll. So with respect to, as you know, there hasn't been really evidence-based medication or guideline-directed medications per se in patients with heart failure with mildly reduced and preserved ejection fraction. We did require patients to be on diuretics, and the vast majority of our patients were on diuretics in this trial. If you look at either loop diuretics or non-loop diuretics, excluding MRAs, it's about 90%. If you include MRAs, it's about 98%. Many of these patients, for reasons that I'm not even sure I understand completely, are on beta blockers. Very large percentage on either ACE inhibitors or ARBs. And we even had a small but finite percentage of patients in this trial who are on sacubitril valsartan. I think what's most amazing about the medication use, though, in DELIVER is that we had very high use of mineralocorticoid receptor antagonists, about 40%, and that's the highest really we've seen in any trial thus far. Emperor Preserve was just a little bit lower, but clearly MRAs are being used in this population.
Right, and FDA approval for ARNIs in the preserved EF category was only given recently. So good use of medical therapies, I would say, for this EF range. Anything else you might add? What is the cutoff of 40% give in terms of an edge for treatment effect? Do you think the lower threshold would favor the estimate of treatment efficacy?
Well, what we've seen, as you know, in many of the trials that have come before DELIVER, let's put Emperor Preserved aside for a second, but in TopCat, in Charm Preserved, and in Paragon, we saw a decline in benefit with ejection fraction going up. And we're pretty convinced that at least in those trials, that was a real finding, because we saw it over and over and over again. And it makes some sense. These are neurohormonal agents. We know that they work in patients with systolic dysfunction. And we think that there's at least some degree of systolic dysfunction up until you get to about that normal range of ejection fraction. Emperor Preserved, as Mikhail already noted, had a hint of attenuation of that benefit in the highest ejection fraction categories. They've looked at these data in a number of ways now, but I think they use that term, attenuation. And that obviously makes us think, well, is this something about the population or is it about the drugs? We're going to have to wait to see the DELIVER results to know the answer to that question. We've got a lot of people in that upper ejection fraction category. DELIVER also had dual primary endpoints in that we're testing the hypothesis for our primary endpoint in the full population and also in the group of patients with an ejection fraction under 60% simultaneously. So we should be able to answer this question hopefully definitively after we see the results.
So I guess we're not getting a sneak peek at the results then. Darn. We look forward to the ESC
I
presentation.
could tell you, but I'd have to kill you both. So
Well, yeah, I guess I'll wait then. But Mikhail, perhaps I'll let you finish. So a larger improvement in health status and perhaps related to the poorer health status at baseline in your trial. And despite the finding of attenuation in clinical treatment effect at the high range of EF, you found persistent benefits in health status. Do you think this might be related to decongestion? Because you did some secondary analyses to show that decongestion was an important mechanism of action.
Right. So a couple of thoughts. One is I would just caution everyone to kind of temper the interpretation of the emperor-preserved data when it comes to this attenuation of benefit and clinical outcomes by ejection fraction, because again, we really need to keep in mind that subgroup analysis have inherent limitations. They're by definition underpowered. They're not corrected for multiple comparisons, and the p-value for interaction wasn't significant. So I think the jury's still out whether that's a true finding or whether it's just an oculostenotic kind of reflex that everybody's having just because it's an ejection fraction. And as Scott said, we'll have to wait till we have delivered data on the clinical outcomes. Second thing that I will mention is health status, so symptoms, function, quality of life are critically important, especially in a half-PAF population. Why is that? It's because while those patients have high risk of cardiovascular death and heart failure hospitalizations, the risks are actually slightly below in that population for those outcomes compared to half-RAF population. But if you look at the burden of symptoms and physical limitations, they're at least as bad, and in many cases worse, in a half-PAF population than it is in a half-RAF population. So I know we always talk about how these outcomes are important, but they're especially critical in a half-PAF population. So if we're able to say that regardless of your EF, we're going to be able to make you feel better and be able to do more by using these medicines, that's an incredibly important clinical goal. And I will also remind you that very few, if any, medicines tested in a half-PAF population have been shown to provide a significant improvement in those important outcomes. Let's take beta blockers. Scott mentioned previously that he doesn't quite understand why so many patients get beta blockers with half-PAF. I would second that sentiment. And in fact, we actually have evidence from a recent trial published in JACC last year indicating that beta blocker withdrawal is actually good for making patients, have better exercise function if they have heart failure.
Chronotropic incompetence, yeah.
Right, exactly. So I don't know, unless there is some other compelling reason like angina or something else or rate control because I have AFib, just using it for half-PAF doesn't really make a lot of sense to me. So we have limited interventions that have shown that kind of benefit. Now, to your mechanistic question, I would say it's likely, and I know it sounds cliche, but it's likely multifactorial. Clearly, there is some decongestion effect. And we've shown, rapid improvement and reduction in pulmonary pressures in our previous trials. Other investigator groups have shown decongestion effects through other means. We actually saw a decongestion effect in the impulse trial in hospitalized patients with either reduced or preserved EF. So there is a decongestion effect, but I think it's just part of what's going on. We're still in the learning phase, I think, really trying to understand all the mechanisms involved and the benefits. And they're clearly very different from other neurohormonal drugs that we've studied in heart failure before.
Right, and decongestion is important. Persistent decongestion with treatment is associated with hospital utilization. So, a desirable mechanism of action among all of the other mechanisms. I thank you both for the generosity of your time, for being here with us, and for sharing these exciting trials. We look forward to ESC. Scott, we'll see you back then. I wish you well and look forward to when our paths cross.
Great to see you. Thank you very much for having us.
Bye.
Bye.